GLP-1s certainly have a place in the treatment of patients for diabetes, and we have really no limitations other than having to have the diagnosis of diabetes, et cetera. And I think everyone covers them for that in some way, shape, or form. Some companies might require previous use of certain other anti-diabetic medications, but oral routes that may or may not have worked, et cetera. Uh, but in general, they're covered. The other use of GLP-1s, depending on the particular version of it you look at, are used for obesity. And so Highmark, from the beginning, has offered coverage for the obesity part of them since the beginning. However, there's new data that's coming out across the industry, both from the insurance company side as well as from the scientific side, and well as from real world evidence side, that show maybe they're not performing up to what we expected them to perform. There's studies that show anywhere from 20 to 58% of those people that start one of these GLP-1s for obesity don't continue past the 4 or 6 week mark. Most of the studies that were done, in the labs for the pharmaceutical companies showed long-term benefits when you stayed on the drug at least 3 months and beyond. The problem is if you take the middle number there, maybe 40% of people don't make it that long for various reasons. Could be cost, could be supply. There's certainly a problem in certain geographic regions with supply of those particular medications. It's a self-injectable tool, as well as it could be side effect. There's a titration effect that you have to do. You start out kind of low and then you work your way up to the full dose. And this is something that's going to make you not feel hungry, not want to eat, and that's one of the ways it helps you lose weight. So in order to do that, you're going to feel a little bit grumpy, right? And so sometimes it's more than just the grumps; it's actually the stomach aches and maybe some sweats and maybe those kind of things. So some people just aren't able to tolerate the side effects to be able to get to a full dose, and so therefore they stop. And when you think of that in a drug that's so costly in that $800 to $1,200 range per month, you have to wonder if we had, just as a for instance, 8,000 members start the drug today for obesity, and 4,000 of those after 6 weeks quit taking it. That means they've gotten 2 doses of the medicine already, maybe 3 or 4 if they're titrating. At maybe they're spending $2,000 to $4,000 to get to that 6 week mark, and it did them a no good medically. So they've not lost any weight. They've not gotten any of the good effects downstream. But now you spent 4,000 times $4,000 on all those patients to not get anywhere with the medicine. And so as a result, we're going to start looking at these things a little more closely to see what's going to happen, and not just at Highmark, but all insurance companies. It's already happening at some of the larger ones. Fully insured are going to have higher premiums if they decide to offer the benefit of weight loss, obesity treatment to include GLP-1s. In other words, if you're gonna say I have a company with, say, 100,000 people and I want to use Highmark, and then Highmark would sit down with you and write a contract to say, listen, what benefits do you want to include? Do you want to include, infertility treatments? Do you want to include obesity treatments, et cetera, from the surgeries to the medications? And if they say yes, you're going to say, well, with this number of members, 100,000 people that work for you, we anticipate X% of those to have obesity. We participate X% of that to want to get on medication. And so you put that all in the pot and mix it up and find out what the premium should be. Well, the premiums are going to have to go up to be allowed to do that. And so we're going to probably move to what's called an opt-in version instead of opting out. So in other words, instead of having the baseline of coverage to include the obesity drugs like GLP-1s, the baseline will be not including them in those fully insured large groups and making those large groups opt in so that we can rewrite the contract to make sure that everyone stays whole and that the money is that the cost of the drug is covered within the premium somehow. That's going to have to help, the supply and demand is going to have to change some, and that will help drive down the cost with competition. Um, but that's not what we're seeing yet. When it was just Ozempic and Wegovy and Manjaro early on, and there was a shortage, and so we thought that's what was keeping the price up, and it was new, so everyone wanted on it, and the pipeline is so full that I think within 1.5 or 2 years there will be an oral version of does something very similar, works the same way. And so what's that going to do? Are they going to try to charge the same cost for 30 days worth of pills as they would for one shot per month or per week or whatever? And so yeah, I mean, intuitively it makes sense that it would bring it down, although there's such a backlog of shortage that's going to take a while to saturate that part of the system, and it's also going to take a while to saturate the workflow of physicians and insurance companies to guide people to appropriate care for those that truly need it, and keep it off of those that don't truly need it, so that there's more available for those that do.